Welcome. So, after the organic brain illnesses and schizophrenia, we come to another major part of psychiatric disorders, something which forms together with schizophrenia major psychotic disorders, and which is a illness from within as compared to something which is caused from outside, are called bipolar disorders. These are termed as bipolar affective disorders. Affect, as we talked about the mood and the emotional state when we are talking about mental stress examination. The other synonymous words are mood disorders or manic depressive illness. This is another word which is used commonly as he is a maniac or he is manic depressive. So, common public recognizes, some people who are familiar with these words, they know that what you are mentioning to is somebody who becomes overtly excited or is out of control, a maniac, or he is depressed. These are very, very common terms which are used, but not everything when you talk about this word actually means a illness. So, when we in psychiatry or psychology or in neurosciences talk about bipolar disorders, we talk about a chronic illness which is mostly episodic. It can be a risk to life at times, and it commonly starts very early, especially in teenagers or young adults. If you look at the epidemiology of bipolar disorders, it normally affects 1 to 2%. Males and females have no difference in having this illness. National Institute of Mental Health in United States of America estimates that 1 in every 100 people have this. Now, if you look at the common newspaper reporting of science and mental health, they often talk of depression being the second largest killer. Now, depression has various varieties and it can be caused by various reasons. It can have a different quality in a lot of people, but if you take people who have who take 100 people who have depression, so you will find at least out of those 100 you will find a significant number who is a part of a bipolar illness. And depression is also, the diagnosis at times becomes difficult because it overlaps with lot of other behavioral syndromes or disturbances, is often comorbid with other illnesses. They are, I will just mention it as we move on. And there is a very strong genetics which is common with bipolar affective disorder and its spectrum disorder. Now, this spectrum disorder can be a part of personality, substance abuse, history, the deliberate self harm, and so on and so forth. So, this overlap at times causes difficulty in deciding whether it is a typical bipolar disorder where the person is having both mania and depression, or it is just a variety of bipolar, which I will mention as we move on. It is the mood disorder, the mood disturbances lasting from days to months or more can be associated with cerebrovascular accident, as we talked about infarct, thyroid disorders, hypothyroid and hyperthyroid both, seizures, epilepsy, in a illness called multiple sclerosis, where there is a periodic damage to the white matter and people find it have the neurological sign associated with it, with infections, with toxicity and with drugs. Alcohol, is cannabis, they are all known to predispose to having mood disorders. Now, if you remember, we talked about the organicity and we talked about organic affective disorders. So, normally whether it is because of any of this cause, then we call it organic affective disorder, and when we do not have a cause, we call it a bipolar. Electrolyte imbalance, especially in old people, where there is a, especially in the old people who are for example, on antihypertensive to control blood pressure, and some of these drugs reduce sodium level in the body. And there is a myth sometimes justified also, that you should eat less sodium. So, people when they are taking less sodium, they are on antihypertensive, they suppose land up in areas where there is a lot of sweat which goes on, they will end up in low sodium levels, this falls below 130 milliequivalent, and at times they can present with a mood episode. Now, this mood episode in itself can be because of hyponatremia, but still when you diagnose it as a mood disorder, whether organic or independent. So, as in schizophrenia 30 to 70% have identical twins. So, what is the history when you take? You either people have episodes of mania or depression, rarely, very rare in a mixed syndrome, both these symptoms are present, but that is very rare. What you mostly find that people can have episodes starting early in life, and maybe they initially in older times they used to have one episode say every 5 years, and as the illness progresses there is a reduction of almost 33% in between the episodes. So, as the life moves on and they become older, the frequency of the episodes increases. One, the second, the duration between two episodes is decreased and the length of the single episode increases. So, like if somebody has an episode at say 25 lasting for 2 months, and maybe another episode at 30 and then at 33 and then at 36 or whatever, maybe the episode will be 3 months or 6 months, or maybe they are having more episodes within a year. But now as we have, we still do not know the reason, but we see a whole lot of range of these episodes. Some people have more than 4 episodes in a year, which is called rapid cycling. Some people have episode every year, some people have in once in 2 years, or maybe associated with certain stress, with life changes, what we call life events. All events in our life are actually having some stress value, whether it is a good stress or bad stress, and these life events have been allocated certain weightage to it. So, life event can precipitate a episode, an episode which was supposed to happen say 2 years from now, and something sudden happens or something planned, maybe a marriage, maybe a pregnancy, will precipitate a episode now. So, that will bring forward that episode which was to happen later. This is called a brought forward time. So, we are seeing, and we really do not know whether the medication which are giving are causing this or sometimes the underlying illnesses, but so people have this wide range of the course of illness. That is one. The second is, some people can have only depressive episode. So, if somebody is having 3 episodes of only depression, we normally call it recurrent depressive disorder. This is called a unipolar depression. Some people have only manic episodes, but we do not call it unipolar mania, although there is one type where you call unipolar mania, because mania is such an excited state that the person after recovery goes into some amount of depression. So, that is always called a bipolar illness. So, but there are people who have both mania and depression. They can have mania and depression separately, or they can have mania and depression connected with it. Somebody can start with the depression and switch on to mania, or somebody may start with a mania, switch on to depression. Often the medication which are also given cause this, like if you give some medicine to improve the depression, the person can, a small percentage can go to mania, or if you give drugs to control mania, they can push the person to depression. So, this is a whole spectrum of thing, mania, depression together in a cycle. Some people have a continuous cycling, they go on, keep swinging. Some people do not reach a syndromal level, but still have mood swings. So, we have to, while diagnosing, we have to really go into the history of this illness, because that will help you to decide whether it is a normal mood swing, whether some person is having a what you call a cyclothymia, it goes into cycle into up and down like a sine wave, and the course of illness is important to predict when the next episode will be there. It can help people plan their life, it can help plan treatment. So, what is this mania and depression? Let us look at into it. Beyond what commonly you call a manic depressive or a maniac. Mania is a state where there is a significant mood change. Now, this mood change is the hallmark of mood disorder, as the word says. So, the person can have elation or euphoria. If you remember from the mental status examination, I told you elation is a sustained state of mind, which is the person is really happy or expansive, and that is very, very infectious. Or it may not be infectious, and the person may be in euphoria or irritable. Now, there are two type of manias largely understood as a state of mind. One is called a irritable paranoid mania, where the person may be irritable and may be very, very paranoid that people are after me, and he may still having disinhibition, increased speech. Now, this irritability and paranoia may be associated with grandiosity. The people are after me because I have certain power to change the world, and that is why people want to damage me. So, the basic idea is a grandiose idea, and the paranoid idea or the persecutory ideas are secondary to it. But unlike schizophrenia, where these delusions and these thoughts and perceptual disturbances are more or less very, very stable and robust and sustained in time, these are very, very, sometimes it can be very, very fleeting. So, because the concentration level and the attention span of manic patient who has mania is very less. So, there is a lot of increased speech and there is a lot of psychomotor activity, the ideas are flying, and so we all must have seen somebody like this. And normally this person you can see is very high and fidgeting with things, maybe doing a lot of goal directed activity, talking too much, talking grandiosity, God is talking to me and I have such powers and the world is after me. You can make out, it is a very, very typical picture. Vis-a-vis depression, where you have to differentiate between what is dysphoria and pervasive. We all become happy and we all become sad. The brain normally has this tendency of what we call affective regulation. So, if you are happy or you are sad, normally it is not beyond certain time limit. Your happiness, if you are very happy, will not last beyond few hours. So, we do not diagnose mood changes within hours, unless they are very disruptive. Now, if somebody is so high that he is going out to set fire to the world, obviously it could be mania. But we all know normal mood swings because of external reasons, but normally the brain pushes you back to a homeostasis, to a normal, your typical mood state. Obviously, it is not going to turn your mood to somebody else's mood, but whatever your mood state, depending on that threshold, the brain normally balances it. But in these people, so you may feel sad, which is called dysphoria. It may continue for a few days. Obviously, if you have failed in your exam, you will feel sad, but still you will find some happiness in some activities, being with your friends, with going to temple or going to your religious place or talking to your parents or talking to your spouse can make you happy. Now, this is a sign, whereas in depression, this depression is called endogenous depression. There is a pervasive sadness, nothing makes you happy. So, we would differentiate endogenous depression from another illness called dysthymia. Dysthymia is a very, very chronic, at least for 2 years, you remain in a state of dysphoria. There may be stressors, there may not be stressors, but your mood remains low, but you are still able to sustain through the world. Your judgment is not impaired and you have insight and you are trying to make your life, find out the stressors that, but still if you are sad, but occasionally you become happy on situations, not so much happy as it is expected, but still that is dysthymia. It is a chronic thing. More people are dysthymic than having endogenous depression. Here, during that period, which is a shorter period, few months, you are really sad, nothing makes you happy. There are negative cognitions like ideas of hopelessness, ideas of worthlessness, ideas of incompetency, guilt feeling. Now, this may be ill founded, this may be not in reality, or it may be because of a real situation, but exaggerated much beyond what is required. There is a loss of weight in spite of normal appetite. There can be mood congruent symptoms, like the mood congruent psychotic symptoms here were with grandiosity. If you are feeling like a manic patient and you are elated, you are feeling God is talking to you, it is mood congruent. You are feeling high and your psychotic symptoms like hallucinations are also in keeping with the mood. Here also it is a mood congruent psychotic symptoms. the depressed person may be hearing a voice telling him that you are very bad and you are not keeping up to the mark in work and you are not taking care of the family, and they may be feeling guilty with negative cognition and they may be feeling a pervasive sadness. So, these two are like, if you take a sine wave, it is like this, it goes like this, you know what sine waves are, it is like it is like this. So, if you draw a normal line here, this is mania and this is depression, you can see it, your going mood is up, here it is down, and it can come in whole variety, it can be like this, it can be like this, it can be like this, anything. So, the criteria is a distinct period of abnormally persistently elevated, and then this is depression. So, in mania, as I said, they are distractible, they are increased activity, psychomotor agitation, grandiosity, there is a superhero mentality, flight of ideas, racing thoughts, activities that are dangerous, and because of the disinhibition there is a lot of hypersexuality. The sleep is decreased, there is a pressure of talk, they are too talkative. All this has to be sustained for some time. So, there is a significant functional impairment in bipolar disorder. The bipolar 1, where there is a full blown episode of mania and a full blown episode of depression, they go through cycles, as I already mentioned. Bipolar 2 is similar to bipolar 1, except that the episodes are hypomanic, as you see it here, in a milder form. Hypomanic people, if you are people who are always on the go and they are always moving, trying to achieve something, they are never almost discouraged by the failures, and at times they may lose judgment. Now, hypomania at times is very creative and very useful when you have to achieve your work, but if it goes beyond a certain point and it starts hampering your judgment and attention span, it becomes a problem. So, largely if you would have read it, and you must have read it, there is a lot of association of creativity and madness. In fact, when they talk of creativity and madness, they talk more about people who have mood disorders. And there are examples in history, people who were given to mood swing, and in mania they would create a lot of things, in depression they would damage themselves. There are a lot of examples in literature, you can just Google it, actually you will find a lot of them. Rapid cycler, as I said, more than 4 episodes in a year. By 10% of schizophrenia patients, almost 10%, they commit suicide, and the risk is much higher with bipolar patients. Lot of this, if you look at number of adolescents who have completed suicides, in a retrospect, what you call a postmortem of psychological disorders or postmortem of psychiatric disorders, you will find at least 22% of adolescents had bipolar, which obviously could have been treated because they are more or less treatable conditions. There is a family history of suicide, substance abuse of any sorts, alcohol, cannabis, and any adolescent which is having what you call a spectrum disorder, impulse discontrol. You will find some people who, normal kids, and there are a lot of adolescents who are brought to psychiatric clinics, and you would have seen that suddenly they are all right, something goes wrong which is not up to their mind, and they will just blow off, they will just become hyper angry and destructive or destroy things, and then later on settle down with have guilt about it, a brief lasting episode, and they as if they have almost lost control. This is impulse discontrol, depression, suicidality, substance use, and access to weapon is a potential for lethality. So, somebody having bipolar, the family history of suicide with drug abuse, with history of anger, and he possesses a weapon, is a sure shot recipe for danger. The major depression, as I said, endogenous depression vis-a-vis dysthymia, often presents in children. We will talk about when we talk about child psychiatry in the last week. Now, some young people can start with depressive illness, and after many episodes of depression may have a manic episode. So, the illness is known to change its course. So, ADHD, conduct disorder, we will talk about these things later. So, we have, now why is it important to know that the person is having depression? So, if you suspect in the people you know, that is, the person has phases of mood swings which are more than any normal person. So, happiness makes the person too happy, out of control, or if you feel that person goes into depression or sadness. Or so when you talk of depression as a common term, not every mood swing is depression, because this is something which you should understand and everybody should understand, because we are already talking about depression as the second largest killer, and WHO predicts that a lot of countries like India will have almost 46% people having psychiatric illnesses, out of which the anxiety disorders, which we will be talking next after this, will coupled with depression is the major morbidity which the population will face. So, when you are talking of depression, you will find a big number of people who have bipolar illness. So, if you find somebody around you who is actually either for a very prolonged period is sad more than what is required, it is hampering its his functioning and his potential, his or her potential into negative cognition, you should suspect depression, right. Now, why it is important, or if you are seeing a person who is very sad for very long, why is it important? Now, there is a common word called counseling. Now, everybody who sees that everybody has a mood swing, go for counseling. Now, counseling is just one mode of treatment, psychotherapy is another mode of treatment, but counseling may not help these people who have endogenous depression and episodic illness. It may help, cognitive behavior therapy has been shown to improve, but now we have very, very effective medication which in fact can improve this. So, medication plus psychotherapy has been shown to have the maximal benefit. It is also important that if there is a protracted course of illness, if there is a course of illness which we have seen the person can control, we should help the person. So, we have medication, the mainstay of the medication is mood stabilizers. Now, these medications like sodium valproate, divalproex sodium, carbamazepine, lithium, all these medications, some of this like carbamazepine, and they are also used in epilepsy. In fact, one of the physiological theory is that is something called force normalization, because it considers that the source of epilepsy, especially in temporal lobe epilepsy, where people have these episodes of seizures, where for brief moment they get into altered sensorium and abnormal behavior. Some people who have psychosis develop a seizure and then their psychosis improves. So, anyway, that is a physiological explanation. So, some of these medicines which are anti-epileptic drugs like sodium valproate and divalproex or carbamazepine, they are the medication which actually stabilize mood. Lithium is another ion which actually stabilizes. This is one of the oldest ones called, and a lot of people on lithium. Some of these work well with mania, some of them new ones like lamotrigine and all work with they work with better with, but there is a whole lot of drugs which are anti-epileptic drugs which are commonly used for bipolar. So, normally what happens if somebody sees a prescription of a person and says, oh, why are you on an anti-epileptic drug? Check out whether the person is on an anti-epileptic drug because of a bipolar illness. The other mainstay is the new drugs which have come in and called atypical antipsychotics, which we briefly mentioned while talking about schizophrenia, are also because these atypical antipsychotics differ from the typical antipsychotics, because typical antipsychotics were working largely on dopamine, and in the other areas they were having side effects working on the different neurotransmitters. These atypical antipsychotics work on dopamine, serotonin, norepinephrine and other type of receptors also. They often help in mood stabilization in their own entity and along with the mood stabilizer. Risperidone, olanzapine, quetiapine, aripiprazole, you will commonly see these drugs being prescribed, especially in India, where a lot of other specialties also write psychiatry medication. They are increasingly used because they can cause rapid stabilization, whereas a mood stabilizer may take few weeks. They can cause a rapid improvement. Olanzapine can help with depression, mania and psychosis. Now, a word about this medication. The medications which work in depression and other anxiety disorders are a common group of drugs, but if you look at antipsychotics and mood stabilizers, anti-anxiety, antidepressant, there is a huge overlap in treatment. Although in schizophrenia, antipsychotics are the main treatment, in mood disorder, mood stabilizers plus antipsychotics are the treatment, whether typical or atypical. Within these groups, if you look at it, so it's like if you may feel that we have a group of, there is a mental state, there is a normal functioning of brain, there is a mental state which is normal or abnormal, we decided by our behavioral observation or testing, we classify them, we put a label to them, and which is the risk also labeling, but we have recognized illnesses. So, we have labels also, and then we mix and match with the group of drugs which we have to treat. Like for psychosis, as I said, two major psychosis, schizophrenia and mood disorder are treated with, the schizophrenia is treated with antipsychotics, typical antipsychotics working on dopamine, atypical which are future development and the as advancement has gone and work on various receptors. In bipolar, antipsychotics are coupled with the mood stabilizers. In depression and anxiety, there are other drugs which work on both or separately. With organic mood disorders, we can use depending on the behavioral syndrome which is created, and there are other drugs which are used in for sleeping and for that we will discuss later on. Now, you can ask me how do you decide and which drug is better? Now, that is a matter of training, and in fact, if you ask me within antipsychotic, no research has shown it, no one antipsychotic is better than the other. Within antidepressants, if you take a cluster of symptoms, maybe there is a small group which works best when there is a mood disturbance along with thought problem, and there is one which works best on the depressed mood, but then none is better than the other. So, within groups, it is the decision making of how and which drug will be used is still, there is a data to back up everything, but largely if you ask me, it is based on the side effect profile, and the hunt is on for more and more specific medicines which we know will go and work in the brain on definite target neurotransmitter system, obviously altering the firing later on of the network and the other neurons, and act minimally on other neurotransmitter systems to cause least side effects. And these side effects, mind you, are not always within the brain, because the same the transmitters like serotonin and everything are spread all over the body, in your GI system, they control the respiratory system, blood pressure. So, they act peripherally also. So, lot of these side effects, so when you buy a drug or you see someone close to you taking a medication, you always, people have a tendency to put it on a Google and look at the side effect, or read that pamphlet which is associated with the book. It always mentions the side effect even if it has happened to one person over years of use. But mind you, all these drugs have been well tried and none of the drug is out in the market unless it is well tried. So, the choice of the drug is based on the side effect and the research backup. So, we will talk about these as we go on to talk about anxiety disorders in the next lecture. So, we will talk about anxiety and obsessive compulsive disorder in the next lecture. Thank you.